Good afternoon, everybody, and welcome to the Gynecological Pathology Community of Interest Spring Meeting. I'm Anna Plotkin, Director of CPD Office at the University of Toronto. And today I'm co-moderating this meeting with Dr. Anjelica Hodgson from the University Health Network. As a reminder to everybody to please mute your microphones. And please fill evaluation forms if you are interested in CME certificates, as well as we will appreciate if you can provide us opinion and recommendations for a future meeting. With that, I would like to pass the time to Anjelica. And Anjelica, please go ahead.
Sure. Hi, everyone. Thanks for joining. We have a great slate today. We're going to follow the usual format that we've been following in the past. We're first going to have a talk by our guest speaker, Dr. David Kolin, who I'm going to introduce in just a minute. And then we're going to follow that with case presentations from Dr. Kolin and from members of our community. And Dr. David Kolin is our guest speaker today, and he obtained his MD from the University of Toronto, and he also has obtained a PhD from McGill University. He completed his anatomical pathology training at the University of Toronto, and he was a co-resident and mentor and friend to a number of people that are on the call today. And he followed that up with fellowship training in women's and perinatal pathology at Brigham and Women's Hospital in Boston, where he now works. And he is a subspecialist in gynecologic pathology, and he's also an assistant professor at Harvard Medical School. And Dr. Kolin has certainly a lot of clinical expertise and kind of wide-ranging academic interests, with his current primary interest being in mesenchymal neoplasia, which is what he's going to talk to us about today, as well as in adnexal and sort of para-adnexal neoplasia. And if you were at USCAP, you would have heard his great talk then. So it's our pleasure to host David, and please go ahead.
Great. So thank you so much for the invitation to speak today. I'm still physically in the US, but it's nice to be virtually back in Canada, at least where I'm allowed to spell tumors with a U in the title slide. And if I can advance, okay. So I have no conflicts to disclose. In the presentation today, we'll review criteria for malignancy and smooth muscle tumors. And talk about how we can approach these smooth muscle tumors when they have unusual features, and be aware of some potential diagnostic pitfalls in diagnosing smooth muscle neoplasia. And then in the second half of the smooth muscle talk, we will discuss FH deficient smooth muscle tumors. I've been told that there's kind of a wide range of people on the call, hopefully from trainees up to practicing GYN pathologists. And so, for better or worse, hopefully there's something that will interest everyone, but there's also going to be parts that will probably bore you because you know them, especially if you're more experienced. But I've tried to include a range of topics in both the smooth muscle section and the cases that follow that should hopefully be of interest to everyone. Okay, and so for the smooth muscle portion, we'll do a case-based presentation. Case 1 was a 47-year-old woman who had a history of uterine fibroids who presented with pelvic pain. Ultrasound showed a pelvic mass, and the surgeon resected a 5-centimeter right broad ligament fibroid, and there were 15 sections submitted for histology. At low power, I think you'll appreciate right away that this isn't a usual leiomyoma. There's definitely some cytologic atypia that's visible at scan and magnification. And at higher power, you can also see these atypical nuclei. And as we zoom in more, there's some definitely some atypia and some mitotic activity. Again, elsewhere, another mitotic figure and some more atypia, and finally, more multinucleated cells and a final mitotic figure. And so this was initially signed out as a leiomyoma with bizarre nuclei, and the outside pathologist gave a comment describing how they arrived at that. They said there's severe cytologic atypia, there's no necrosis, and the mitotic count is 3/10. And based on those three criteria, it was classified as a leiomyoma with bizarre nuclei. Unfortunately, if you go to the very last slide and you look around a little bit more, you can see the hint that there's something significant there because it's marked by that ominous black ink. And on higher power, you can see a wealth of mitotic figures. Of course, in combination with the cytologic atypia, when you see this many mitotic figures, this is actually a leiomyosarcoma. And this was re-reviewed because the patient had a pelvic recurrence 4 years later of the leiomyosarcoma. And in retrospect, if you hadn't noticed that area of high mitotic count, one of the mitotic figures I showed you at the beginning was an atypical mitotic figure, and we'll come back to the importance of those and what those mean in smooth muscle tumors. So when we think about smooth muscle tumors with atypia, cytologic atypia can be seen in benign tumors, which would be a leiomyoma with bizarre nuclei, which are also called atypical leiomyoma, symplastic leiomyoma, or a leiomyoma with symplastic change. And they can be seen in malignant tumors, of course, like leiomyosarcoma, as well as smooth muscle tumors of uncertain malignant potential. And we'll go through these. So leiomyoma with bizarre nuclei, there are no really specific gross findings to tip you off that you might be looking at one of these, but microscopically, they have moderate to severe cytologic atypia, as the name implies. This atypia can be focal or diffuse. The cells are large and hyperchromatic with clumped chromatin often. There may be some cytoplasmic inclusions. In a leiomyoma with bizarre nuclei, you really should not see any tumor cell necrosis, and mitotic count is below 10/10. The prior comment referenced the so-called Stanford criteria in diagnosing smooth muscle tumors, and that goes back to this AJSP paper from 1994 by Bell, Kempson, and Hendrickson, where they identified that the three most important features to evaluate in smooth muscle tumors are atypia, mitotic rate, and necrosis. And in this series, they looked at tumors with more than 2 years of follow-up to identify features which could predict malignancy. And so to diagnose leiomyosarcoma, you need 2 of 3 of these cytologic atypia, mitotic index greater than 10/10, and tumor cell necrosis. If you just have one of them, then it's probably a variant of a benign leiomyoma. So for example, if you just have cytologic atypia, that would be an atypical or symplastic leiomyoma. If you have a mitotic count greater than 5, it's probably a mitotically active leiomyoma. And the exception would be tumor cell necrosis, because if you see really good tumor cell necrosis that's unequivocal, then you're at least a stump based on that. And now we'll go through each of these 3 features and talk about what we look for when we diagnose them and some potential pitfalls. So in terms of cytologic atypia, this should really be significant atypia that you can see at scanning power with a 10x objective. And so on the figure on the right, you can see that even on this low power image, there are some nuclei that stand out. And when you go up on higher power, you do in fact confirm that there's nuclear enlargement and coarse chromatin and variation in nuclear size and shape that count as atypia. What you shouldn't do is go up to 40x right away and look around and see if you can see any mild cytologically atypical cells, because those changes really don't predict clinical behavior, and they don't count as cytologic atypia for the purposes of malignancy. So here's an example with, I think, really significant and striking cytologic atypia at low power. And when you go up higher, you can see that these obviously atypical cells are characterized by nuclear enlargement, variation in nuclear size and shape, and with coarse chromatin. Elsewhere, like in the cell towards the bottom of the image, you can see multi-lobation or multinucleation in the nuclei. And when you're looking for nuclear enlargement, it can be really helpful to compare it to the surrounding normal myometrium. So on the left, you have the normal myometrium, and on the right is a leiomyosarcoma, where the nuclei are obviously enlarged compared to the benign smooth muscle on the left. As well, it can be helpful to compare the normal myometrium when you're looking at changes in chromatin. So on the left, benign myometrium, and on the right, a leiomyosarcoma, where the chromatin becomes coarser in comparison to the normal myometrium. And if you frequently review cases from outside institutions or from other hospitals, it can be very helpful to compare it to the surrounding myometrium, because different hospitals will stain differently with their H&E stain, and it's nice to have that kind of internal control to compare it to. In terms of the distribution of the atypia, it's not really included in the classification of benign or malignant, but it can be helpful just to be aware that you can see different distributions of the atypia. So here's an example with diffuse atypia that's throughout the tumor, but you can also see multifocal or zonal atypia that is similar to what you'd see in a symplastic or a leiomyoma with bizarre nuclei. And therefore, it's really important to look at the other characteristics like mitotic figures and necrosis to help classify this tumor. And then the third pattern is this multifocal atypia. So the arrows indicate those atypical cells that stand out in the background of relatively bland, smooth muscle. And again, all three of those patterns would count in terms of satisfying the criteria for a leiomyosarcoma. Moving on to mitotic activity. So you want to count adjacent high power fields. You can't skip around to the areas that are the most mitotically active. I find it helpful to count at least 30 to 50 fields. And really, just as important is you'd like to scan around at low power and look for proliferative hotspots, and obviously count there and use those areas for your mitotic counts. A Ki-67 proliferation index isn't used in the classification of uterine smooth muscle tumors, but sometimes it can be helpful to help highlight those areas of the tumor that might be more mitotically active, to go back to the H&E and count mitotic figures. One potential pitfall is that you can see increased mitotic activity beneath surface ulceration, as you can see here, and you can also see increased mitotic activity around the area of just ischemic change. And so it's important to be aware of that. And if you see increased mitotic activity either beneath surface ulceration or adjacent to ischemia, then you may want to move elsewhere to conduct your counts. One potential pitfall is overcounting mitotic figures, and pycnotic nuclei can be a real mimic of this, because you don't want to count degenerating cells and overestimate the true mitotic count in a tumor. So here's an example of what I think is a real mitotic figure. It has distinct chromosomes visible with some hairy extensions of the chromatin. And this is in contrast to a pycnotic nuclei. So on the left, the arrow shows a degenerating cell. You don't really see distinct chromosomes, and the other tip-off is that the cytoplasm is really eosinophilic, which suggests that it's a degenerating cell. And you can compare that to the true mitotic figure indicated by the arrowhead in the top upper right. Here are some more examples. The true mitotic figures, or at least what I would classify as true mitotic figures, are indicated by the yellow arrows, and the blue cells with the glassy eosinophilic cytoplasm, I think, are pycnotic and dying, and I would not count those as mitotic figures. And just to emphasize that overcounting mitotic figures can be a real pitfall in smooth muscle tumors, because you can bump it above the 10 per 10 threshold and call things leiomyosarcomas that perhaps should not be classified as such. So now moving on to necrosis and issues associated with that. So in true tumor cell necrosis, one feature is this geographic appearance. So it should have a complex contour that looks like it could be outlining like a geographic area on a map. As well, in coagulative tumor cell necrosis, you see a really sharp transition. On the top left, you have the viable leiomyosarcoma. On the bottom right is the dead tumor. And finally, in tumor cell necrosis, if you go into the areas that look dead, you'll often find atypical ghost cells. So the cells might be necrotic, but they still have a cell border and cytologic atypia that you can see in the areas of necrosis. And so in contrast, ischemic or degenerative necrosis has different features. One is it has a smooth and rounded contour between the viable tumor in the bottom and the area of central hyalinization in the top. As well, there's a blurred transition between the viable cells and the dying cells. And similarly, you'll find a zone of fibroblastic repair between the viable tumor in the bottom left and the ischemic area in the top right. And in leiomyomas that have ischemic change, if you go up on higher power in the dying areas, you'll find that they're really bland ghost cells. And so if we just contrast coagulative tumor cell necrosis, which would count if you're looking for a leiomyosarcoma, it tends to be multifocal in contrast to the ischemic necrosis, which is usually single and centrally located in the tumor. Coagulative tumor cell necrosis has that irregular contour in contrast to the smooth or rounded contour that you see in ischemic necrosis. There's a really sharp transition between viable and dead tumor in coagulative tumor cell necrosis in contrast to the blurred transition that you see in ischemic necrosis. You see fibroblastic repair in ischemic necrosis, but not in coagulative tumor cell necrosis. And finally, if you go up and you look at the dead cells, usually the ones in coagulative tumor cell necrosis will look atypical in contrast to the very bland dead cells in ischemia. It should be said that even though tumor cell necrosis is one of the most important features used to classify smooth muscle tumors, it can be really hard in cases where it's ambiguous or features are overlapping. This was a series that came out about 10 years ago where 6 very experienced GYN pathologists classified or tried to classify necrosis in smooth muscle tumors, and there was only full agreement in 35% of cases, partial agreement in about half of cases, and no agreement in 18% of cases. And so it can be challenging to distinguish in cases with ambiguous features. Grossly, there's differences between benign smooth muscle tumors on the left and leiomyosarcomas on the right, which have extensive hemorrhage and necrosis. But having said that, degeneration can really mimic malignancy. Here's an example of a leiomyoma that just has degenerative and ischemic changes. On the right, it's prolapsed out through the cervix, and it's become torus and ischemic. And, I think grossly it can really be a little bit frightening. And so that's why it's always important to correlate the gross with the microscopy as well when you're classifying these tumors. Okay, so now we'll look at some examples of necrosis and see what people say. I know you're all muted and there's no voting or anything, so you can just vote silently in your head. So do we think this is coagulative tumor cell necrosis or ischemic type change? I'd say this is, personally I'd classify this particular area as ischemic. The cells do look atypical, and this is actually an example from a leiomyosarcoma, but leiomyosarcomas can have areas of ischemia too, but you can see there's no sharp transition, and the dying cells are kind of admixed with the rest of the tumor. Here's another example. Again, I think the atypia jumps out, but you can also appreciate that there's an area of fibroblastic repair or a transition between the viable tumor on the left and the dead tumor on the right. So this would be an infarct or ischemic type change. In contrast, here we have an example that I think is coagulative tumor cell necrosis. On the left, you have the viable tumor, and on the right, the dead tumor, and there's a very sharp, abrupt transition between those two areas. And so smooth muscle tumors of uncertain malignant potential are used as kind of a wastebasket for tumors that are difficult to classify because they seem like they're more than you would expect in a leiomyoma, but not quite enough for a diagnosis of leiomyosarcoma. And because the WHO classification is a little broad, I think different pathologists and different centers may diagnose them a little bit differently, and as such, you get a tumor classification that's very heterogeneous, and these tumors have very variable outcomes depending on how likely someone is to diagnose them. And that's why if you look in the literature, the rate of adverse outcomes can really vary between 4 and 36%. In practice, one way to think about STUMP is if you're sure that there's one of the criteria for a leiomyosarcoma, but you're not quite sure about the second one. So for example, there might be really prominent cytologic atypia, but the mitotic count might be 8 or 9, so not quite at 10. Or the other one could be if there's atypia, but the necrosis is difficult to classify, and you might show it to some colleagues, and some people think it's tumor cell necrosis, and other people would classify it as ischemic. That would be another case where you could diagnose it as a STUMP. There was a nice paper in histopathology several years ago that looked at some additional histologic features that can help classify these smooth muscle tumors. And the ones that they looked at were destructive infiltration. And so if you see that, even without any other worrisome features like atypia or a really high mitotic count, then I think you'd be warranted to call it at least STUMP based on that destructive infiltration. Here's another case where you can see the tumor of a leiomyosarcoma really percolating through and infiltrating the surrounding myometrial fibers. The other feature is atypical mitotic figures. So these would be mitotic figures with lagging chromosomes or multipolar mitoses. The last thing that would let you call something an atypical mitotic figure is if it's obviously aneuploid, meaning there are like way too many chromosomes for the cell. But in practice, I think that can be difficult to apply because it's not like you're counting the individual numbers of chromosomes. So you just want to be careful you don't overcall in that situation. But if you see atypical mitotic figures, that should also be a warning that you're dealing with something that's probably at least a smooth muscle tumor of uncertain malignant potential. So if we go back to our criteria for leiomyosarcoma, certainly you want to look at cytologic atypia, mitotic index, and tumor cell necrosis, but you also want to be attuned to whether or not there's myometrial invasion, any atypical mitotic figures, or vascular invasion as well. I won't go through this flow chart, but if you want to know how these can all be incorporated to kind of reach a diagnosis, the reference for that histopathology paper is down at the bottom, and you're welcome to check it out for more information. So what's the take-home messages from case 1? Well, I think a few points. One is that sampling is really important. You want to make sure that the tumor is well sampled. You don't want to rely solely on coagulative tumor cell necrosis because there's a lot of interobserver variability and it can be difficult to diagnose. So be careful, and also search for cytologic atypia and count mitotic figures very carefully. If you see any of those 3 red flags, destructive myometrial invasion, atypical mitoses, or lymphovascular invasion, you should really consider a smooth muscle tumor of uncertain malignant potential. So moving on to case 2. This is a 30-year-old woman with uterine fibroids who underwent myomectomy. The specimen consisted of 500 grams of pink tan tissue. I think on low power, you can notice that there's some atypia. As we get higher, it becomes more and more pronounced, and even higher, you can see there are these enlarged cells, some of which are multinucleated, and they have, or some of them at least, have this very peculiar finding of a prominent nucleoli surrounded by a perinucleolar halo, like that cell indicated by the arrow. And if we cruise around a little bit more, we can see other nuclei that have very similar changes. Elsewhere, the atypia may not be nearly as striking, and the cells look more bland, but if we go up higher, they also have those characteristic nuclear changes. As we search the tumor, we'll notice some of these vessels have unusual patterns that look like HPC-like vessels or staghorn vessels. Elsewhere, the cytoplasm has a very fibrillary quality, and in some areas there are these eosinophilic hyaline globules in the tumor as well. And I think, as most of you have probably recognized at this point, we performed an FH stain, which was lost in the tumor cells and retained in the endothelial cells, which serve as an internal control. And so this is an FH deficient atypical leiomyoma. In practice, if you're curious, these are how they usually get signed out: fumarate hydratase deficient atypical leiomyoma. And there's a comment saying that there should be consideration of medical genetics consultation with testing for the FH gene mutation, as well as dermatologic examination and screening for renal cell carcinoma. And we'll talk a little bit about each of those features. So back in 1973, Reed described 2 families that had cutaneous and uterine smooth muscle tumors, and that's why the syndrome is known as Reed syndrome, or hereditary leiomyomatosis renal cell carcinoma, HLRCC. It's an autosomal dominant pattern of inheritance with incomplete penetrance. And it was later on that people discovered that there was actually an association with renal cell carcinomas. And in Reed syndrome, there's a germline mutation of the fumarate hydratase gene with heterozygous loss of function. So, I thought after med school I was finally done with the citric acid cycle, and it was to my great disappointment that something in my day-to-day life might have some relevance to it. But fumarate hydratase, or fumarase in this diagram, mutations in it cause a metabolic derangement in the cell, and because of the mutation, it's like the cell is in a pseudohypoxic state, and it results in hypoxia-inducible factor 1 alpha upregulation. And you'll notice there's an accumulation of the upstream substrate, succinate, and that results in an accumulation of aberrantly succinated proteins, which we'll come back to in a little bit. So when we think about Reed syndrome and the lifetime risk of different tumors, between 70 to 100% of patients will have cutaneous leiomyomas at a mean age of 25. 80% of women will have uterine fibroids at an age of 30. And then the fumarate hydratase deficient renal cell carcinomas are much less common, so less penetrant than the uterine fibroids and the cutaneous lyos, but they do occur at an older age. and they are extremely aggressive. And so the uterine fibroids really give an ideal way to identify these patients 15 years before they may develop the really aggressive renal cell carcinomas. And so they can get referred for germline testing and screening for the RCC, which is the real risk to these patients. Just for fun, microscopically on the left is an FH deficient renal cell carcinoma, and you can see the nuclear changes in the RCC really mimic what you see in the uterine FH deficient leiomyomas. And for some reason, which is not clear to me at all, the cutaneous leiomyomas in these patients just look like really bland, smooth muscle tumors, but they too also show loss of the FH protein. There's been a number of papers that have looked at these, and I won't go through them in great detail, but just to point out some highlights. It was shown that in these fumarate hydratase deficient leiomyomas, there is loss of heterozygosity in the patients with Reed syndrome, as I mentioned, which accounts for the second hit to the gene, so both copies are lost. There are a number of histologic features, as we mentioned, including the nuclear atypia, the staghorn vessels, the cytoplasmic inclusions and fibrillary cytoplasm, as well as alveolar type edema, which we'll see shortly. And the loss of the FH protein can be detected by IHC, which is now widely used. And as I mentioned, because of the abnormal succination, because of the buildup of succinate, you can stain with 2SC, and that will be positive in the tumors, unlike the FH, which is lost, and so it provides a nice secondary stain. Here's an example with beautiful alveolar type edema in the top left, really characteristic nuclear changes in the bottom left, and so you're really sure this is an FH leiomyoma, but you do the FH stain in the bottom right, and it's actually retained. And so this would be a case where 2SC would be very helpful if you had that available, because it would be positive in the tumor. And again, just to highlight series that have shown that FH can be retained even in patients with HLRCC. And this is due to missense mutations in them, as other studies like this one have highlighted. Similar changes can happen in both HLRCC and frequently in sporadic tumors. And if you see multiple leiomyomas with FH deficiency, that should be another feature that should tip you off that the patient could have a germline mutation in HLRCC. If you look at all uterine smooth muscle tumors and see how frequently they have loss of FH, the number can vary from series to series. In this one, for example, that was very large, they had over 1,500 uterine smooth muscle tumors. They saw FH loss in around 5% of them. In this series, they didn't have any leiomyosarcomas with FH loss, but that hasn't quite been our experience, which I'll discuss in a second. Here's an example that has metastasized to the lung, as you can see in the top left. There's obviously significant cytologic atypia. There's some staghorn vessels and cytologic features which are characteristic of FH deficiency, and indeed FH was lost in this tumor. And in our experience, we see fumarate hydratase loss in about 2% of leiomyosarcomas, which was reported in this series by David Chapel, who looked at over 300 leiomyosarcomas and stained them all with FH. Which is just to say that FH deficiency can be seen in atypical leiomyoma, stump, and leiomyosarcoma, and the presence or the absence of the FH staining shouldn't sway you too much in how you classify these smooth muscle tumors. One tricky area that I think is still up for debate is that, of course, the FH deficient smooth muscle tumors have baseline atypia, which makes them look unusual, and it's difficult to know exactly how that atypia should be factored into classifying these tumors and whether or not that baseline atypia counts as one of the criteria for leiomyosarcoma. I think most people would say that the atypia and the cellularity should usually be higher than what you see in a typical FH deficient leiomyoma. Of course, if you see a high mitotic count, atypical mitotic figures, or an infiltrative border, all of those would be helpful, but it's difficult to come up with really rigorous criteria because these malignant FH deficient smooth muscle tumors are incredibly rare. Okay, so to summarize the second part of the talk, if you see bizarre nuclei or other features that might make you think of an FH deficient smooth muscle tumor, I would stain for both FH and 2SC. If the FH is lost, you can consider the possibility of Reed syndrome, but be aware that the vast majority will be due to somatic mutations. And things that should really make you think about the possibility of HRCCC are if the FH deficient tumors are multiple, if the patient has a family history of renal cell carcinomas, and obviously if they have cutaneous leiomyomas. It's difficult to know for sure, but some series have speculated that around 3% or 5% or 8%, or in any case, it's a minority of these FH deficient tumors will harbor germline mutations. But because the renal cell carcinomas are so aggressive, I think most people would err on the side of mentioning it in the report so they can be referred for appropriate screening. And so just to wrap up the smooth muscle portion of the talk at least, you should be wary of smooth muscle tumors with significant atypia. So count mitotic figures carefully, look for atypical forms, and make sure you sample the tumor well. And that would be areas that look different grossly, especially if you're able to sample where transitions between either the tumor and the surrounding myometrium to look for invasion, and then the areas of necrosis and the viable tumor as well. Both of those can be very helpful to accurately classify the tumors. And that is all I had for the first portion of the talk. There's my email if people would like to email me any questions, and I'm happy to take questions now, or we can hold them until later, however you normally do it.
Yeah, awesome. Thanks, David. There is some very practical questions in the chat. Hopefully we'll be able to get to them. So first question to you is about distinguishing early infarct from true coagulative necrosis, and any tips that you have about how to go about that.
Yeah, so, even if it's abrupt, we can still look at the other features to help us decide. And so, for example, if I'm looking at a tumor that totally looks like a usual type leiomyoma, and even if it's abrupt, but the ghost cells don't look atypical at all, and it's a rounded contour and it's central, then to me that just the fact it's abrupt is not so concerning, assuming everything else is reassuring, which they usually are in otherwise benign smooth muscle tumors.
Maybe, David, just to follow up on this question, if there is a question, if you see increased mitosis only next to the area of necrosis, how do you really make the diagnosis, whether it's benign, malignant, or stump? If I assume the question is there are no increased mitotic count elsewhere. Sorry, could you repeat that? So if there is increased mitosis in the area next to the necrosis. Yeah, so so I would not call it a leiomyosarcoma or even necessarily use that in the classification of it if the rate was only elevated adjacent to the areas of necrosis, but really to scour the tumor elsewhere, or even, I think a really helpful thing is just to go back and submit more sections if what you have is maybe not diagnostic, and that can help either reassure you if the rest of it looks
without mitotic figures or other worrisome features, or you might, in the additional sections, find an area with a high mitotic count. And so, in practice, I think often, we'll see smooth muscle tumors in consultation, and we can only really look at the same glass slides that you can. So, of course, you can send things out for consultation if you're not sure, but sometimes the most helpful thing is to go back and submit more sections and sample areas of transitions from ischemia to viable and from the tumor to the surrounding myometrium, and to just see if you can find increased mitotic counts. But no, if there's only increased mitotic figures around the areas of ischemia, I wouldn't call it, a stump or something just based on that one area.
Speaking of stump, you alluded to the kind of diagnostic issues, and there's also clinical issues as well, right? And again, you alluded to some people really like to use stump, and some people, tend to not use it as frequently. And
right.
And one of our colleagues is asking here, so if you've made the diagnosis of stump, what are the next steps in patient management, particularly if this is not a hysterectomy specimen?
Right. I think part of that will come down to the patient's preference and the surgeon's preference, and whether or not the patient is postmenopausal. For example, if you diagnose something as at least stump on a biopsy specimen in a postmenopausal patient, I think most clinicians would have a relatively low threshold for proceeding with a hysterectomy. Whereas if the patient's, unfortunately, sometimes we see these very difficult cases in young patients who understandably want to maintain fertility. And there, I think it's a difficult conversation where they may consider monitoring for regrowth. If they're really set on maintaining fertility. But I think a lot comes down to the surgeon and the patient and what their goals are.
And maybe, David, I will summarize a lot of the questions. If there is any immuno or molecular that helps you to distinguish benign versus stump versus leiomyosarcoma, anything that you use, let's say, often in your practice.
So yeah, there was a nice paper from Memorial Sloan Kettering maybe a year ago that looked at immunohistochemical markers that can help classify tumors. And the short answer is that I don't, I think that can be further validated with perhaps some more published studies. There was a little bit at USCAP this year in terms of that, and as well, the molecular is interesting, but that is certainly not incorporated into our routine clinical practice. And so we usually just honestly rely on H&E to classify these smooth muscle tumors. Occasionally, we may order a P16 or a P53, and if, for example, we were on the fence and it shows a mutant P53 staining pattern, that would obviously make us more concerned. But the bedrock of the diagnosis really relies on H&E diagnose, the diagnostic features for now, but that could certainly change in the near future.
David, what about any tips you have for people about, particularly young patients? They have all sorts of leiomyomas, they're put on all sorts of medications to decrease the size and such prior to surgery. And we know that some of these medications, including Fibristol, can cause some morphological changes that may be confusing. Do you have any tips on how people can navigate that type of stuff?
I mean, the short answer is no, not beyond what I said. Sometimes they can look more ischemic or cause some reactive type changes, but no.
History is good, right?
It's helpful if you get it, but so often we get so little.
Yeah, for sure. Just last thing about your first part, David. FH, I think most people are aware of this now, and we're pretty good at recognizing this. And then FH-IHC is pretty widely available now, and you're really confident with FH deficiency in terms of morphology, and then you get the stain and it's not lost. And
Yeah.
and 2SC isn't exactly available for most people. So what is your recommendations for people from a report perspective in that scenario?
Right. So first of all, if you have 2SC, I would recommend doing FH and 2SC on all of them. But if you only have FH and it, it kind of quacks like a duck and it looks like a duck, but the FH is just intact, then you can describe it out. You can, describe it with a comment saying a typical leiomyoma. See comment, although it shows features that are suggestive of FH deficiency, the FH stain is retained. Occasionally, FH staining can be retained in cases with missense mutations, and clinical correlation is suggested. To see, I think if the patient, obviously, if the patient's covered in cutaneous lyos and they have a history of RCC, that would make you very, very suspicious. But the clinician may also say, no, the patient has none of these features. There was just a single isolated leiomyoma, and they may not get referred for genetic counseling. But we will still certainly raise that possibility in the note, even if FH is retained. And we did that before we had 2SC brought online.
Yeah.
Yeah.
Last question is your kind of approach to using FH. Do you stain all sorts of blocks? Do you, is particularly if there's kind of discrete tumors, do you just focus on the single dominant lesion, or do you have any other kind of way that you approach that?
Yeah, so, generally it's uncommon to see multiple distinct lyos with FH features in the same hysterectomy specimen. So if it, for example, if it was an in-house case and I had access to it, I probably would, and that would, I think, cause you to push the possibility of HLRCC a little bit harder in your comment and make the, just raise the clinician to that possibility. But if it's an outside consult and you don't have them, then you might just, for example, describe the morphology and again suggest genetic counseling.
Okay, great. Thanks a lot, Dr. Kolin. I think we'll move on to cases now. And we're going to start with two cases from two of our participants. Dr. Paliga is going to go first.
Okay, so this is a case that was on my desk actually last week. I got this case, and it was a 39-year-old female, and it was resection of a fibroid. And at the time that when I first looked at the case, I didn't know exactly the size of the fibroid, but I had 3 sections of it. And then later on, I went and looked at the clinical history and found out that it was approximately 1 centimeter in size. There's no imaging. But at time of C-section, they noticed it at the edge of the incision. And when I looked at the sections, I saw spindle cell neoplasm. That one thing that I noted at first on low power was that I didn't see many thick-walled vessels. And I know that's a feature that sometimes that will bother me for a leiomyoma. I like to see thick-walled vessels. I also noted that there were focal areas of inflammation. But otherwise, on high power, it looked just like a leiomyoma with bulbous nuclei and scattered mast cells. There were occasional mitotic figures. I got to 5 out of 10 high power fields. And then arguably some were a bit atypical with flagging chromosomes. And I ordered an ALK protein and it came back positive, diffusely positive in the section I ordered. And so this case was signed out as inflammatory myofibroblastic tumor. And overall, there was no atypia seen. The mitotic count was up to 5 mitotic figures per 10 high power fields. There was no lymphovascular invasion or necrosis identified, but I couldn't tell if the lesion was completely excised or not, as I didn't have the edges of the lesion. And so just to in terms of when I was writing the comment, I decided I wanted to look up what the risk factors are for IMT, and you know, in order anticipating that the clinicians would want guidance on what to do with this case. And so in the Fifth World Health Organization, tumor size greater than 7, moderate to severe cytologic atypia and high mitotic count and lymphovascular invasion are associated with aggressive course. But overall, prognostication isn't very well defined. Recently, there was a paper by Ladwick et al., where they proposed the risk stratification model. And in their risk stratification model, they decided to assign 1 point for older age, size greater than 4 centimeters, and more than 4 mitotic figures per 10 high power field. And if you had more than 1 point, it would be a determined intermediate risk. And then if it's intermediate risk, then you perform next generation sequencing if available, and you look to see if it's an ALK fusion alone, then it's low risk. But if there are additional alterations, you would consider this a higher risk lesion. And so essentially I followed that advice and I sent it for next generation sequencing, which is still unfortunately pending. And then interestingly, this review also talked about pregnancy-associated inflammatory myofibroblastic tumors, which I admit I hadn't really heard about prior to this case. But so there are pregnancy-associated inflammatory myofibroblastic tumors, and these are typically small, and all described cases to date were either attached to the placental disc, the placental membranes, or expelled from the uterus as a separate entity from the placenta, but also from the uterus. And the morphology of these is identical to those identified outside of pregnancies. They do have ALK fusions, but specifically they're enriched for these two fusions, TIMP3 and THBS1. And they've done testing, and some the ones that have been tested were of maternal rather than placental tissue origin, because there was the question of whether or not these are arising from placental tissue given their association with the placenta. And all of these all the reported cases have done really well. So yeah, and so far we haven't talked to the clinician or had any follow-up, so that's all I have to say about that case.
Awesome. Cool. We're gonna hold that thought and do another case as well, in the same vein. That's Dr. Nofek Moses is gonna present her case, and then we'll get Dr. Kolin's thoughts.
Maybe Alex, can I quickly ask you, what tipped you to order ALK stain, and did you order any other stains?
It was a lack of thick-walled vessels and the inflammation, the focal inflammation. I honestly, I didn't know the size of the leiomyoma at the time. I got 3 sections, and I saw the patient was young, and it was a partial resection, so that also, when there's a resection, I'm sort of more prompted to do it than if there's an excision and I can see that it's small and I can see what it looks like, that it's well circumscribed or not. So yeah, so anyways, that's what prompted me. And then I also did an FH kind of just as an add-on because she's young, but that isn't very logical. But yeah, no, just a ALK and a FH.
Okay, so maybe I'll present my case. The patient is a 40-year-old woman who presented with unilateral ovarian mass. It was 12 centimeters in size. And she has been taken to the OR, and we had a frozen section where an ovarian endometrioid adenocarcinoma was diagnosed. So she ended up having a total abdominal hysterectomy, bilateral salpingo-oophorectomy. She had some left pelvic nodes excised, omentectomy, and actually also resections of some sites that were suspicious for endometriosis. So her final diagnosis in terms of her ovarian mass was the endometrioid adenocarcinoma grade 1, stage 1A. And we will be talking about an incidental finding. So her hysterectomy did show multiple fibroids, and the largest was 4.5 centimeters. And here are a couple of sections from this larger mass. I do apologize for the fact that it's not the most beautiful picture or section ever, but that's what I have. On a very, very low power, what prompted me that maybe there is something here is the fact that number one looked a little bit irregular at the border. Also had some areas that looked a little bit bluish versus other areas that are not as bluish and maybe more cellular. There is one thick-walled blood vessel here, but I'm not sure that this is part of the lesion or the myometrium adjacent to it, because they really, when you focus on that area, is probably part of the uterine wall itself. Why doesn't it move? In 1 second. Okay. And here is the lesion on somewhat a higher power. You can see here this irregular outline, and not much to say other than that on low power. On a higher power, we have these cells that, you know, when you stare them long enough, maybe you see some prominent nucleoli. I moved around. I saw more prominent nucleoli. I thought, maybe that's an FH deficient tumor. Well, if I'm going to order this FH with our turnaround time, I might as well do a panel. I actually did a panel, and but I want you to think in your heart whether you would have just signed it out as conventional leiomyoma, or would you actually stain it for FH, or do you think that it looked a little bit myxoid and you would stain it for ALK1? Maybe the tongue-like borders would prompt you to consider reassess, and then you will have some more stains. Anyways, I did the whole shebang. It is a Desmond positive, Caldesmond positive. It was negative for HMB45, and FH is retained. And here's my ALK. So it does show a strong granular cytoplasmic expression, and also had this perinuclear, but also nuclear stain. So because this pattern is associated with the ALK fusion, I thought, well, maybe I should test it. I also went back and looked more carefully at the tumor. And here are just examples of areas where you can actually see that there is lymphoplasmacytic, mostly lymphoid, inflammatory cell infiltrate, but it wasn't now you see here the four areas that I photographed. It was quite subtle. It wasn't in your face. So I sent it for the fusion panel, and it came back as a positive for ALK fusion. And therefore, I signed it out as uterine mesenchymal tumor classified within the spectrum of inflammatory myofibroblastic tumor. I felt that morphologically it came a bit short. Admittedly, I felt that I picked it up mainly because I included it in the panel. My level of suspicion ahead of time, ahead of this IHC, was fairly low for ALK. I was happy to call it FH deficient. And I showed it twice in our consensus meeting, and my colleagues were not too happy to pull the trigger on IMT ahead of the molecular. But with that, we succumbed to the diagnosis. I spoke with the surgeon. She asked me, oh, hey, IMT, that's nothing, right? So that's a gynecologist. And just for us to know that this is within the spectrum of uncertain malignant potential. And I told her that this was not particularly showing any malignant features. Probably she needs to follow up on that because the patient has already adenocarcinoma of her ovary. She will be followed anyways. So now there is just another small headache to the whole package. That's it.
David.
Yeah, so I mean, both of those I think were awesome pickups that a lot of people, if they were on a busy surgical service, might have just signed them out both as leiomyomas. And I think they both highlight a lot of the challenges that you see with IMTs because they can be fascicular like smooth muscle tumors, and they can stain positive for desmin like smooth muscle tumors, and you can see some inflammation in smooth muscle tumors. And so it can be really hard sometimes. You know, the inflammation is obviously a tip-off if you see it, or myxoid areas, and I think for those reasons we have a pretty low threshold for staining with IHC. If definitely if we see myxoid areas, and inflammation, it probably depends on how extensive it is. But I think both of those cases could have been signed out as leiomyomas. And maybe I'm just trying to make myself feel better. But for both of those cases, the second one was at the time of hysterectomy. So perhaps even if you missed it, you never would have heard anything about it. And the first one, was small and didn't have any other high-risk features. And it seems like the pregnancy-associated ones tend to be indolent. And so I hope that, who knows how many IMTs I've missed already, but you hope that most of them behave indolently. Alex mentioned that the pregnancy-associated ones tend to behave well. And in one of the earlier IMT papers, I think they mentioned that the ones that really have extensive leiomyoma-like areas also tended to follow relatively benign courses, and it's the ones with more myxoid or high-grade cytology or infiltrative borders that you might hit, get flagged more easily when you're looking at the H&E, that tend to follow an aggressive course. What else can I say? I can add a couple of things. I don't know how helpful they are, but at least in our institution, if we want to rule out an IMT, we'll stain for both ALK and ROS1. As you know, the ROS1 ones are like vanishingly rare, but if we're staining it for ALK, then we'll throw on ROS1 just to see anyways. If they're positive for the IHC markers, then we usually will not do confirmatory molecular testing. And I guess the reason for that is severalfold. One, it may not be financially possible if it's an outside consult or if the patient's insurance won't cover it. Two, and this is probably the most important, the clinicians just haven't been asking for it for risk stratification or management. So it doesn't seem to have maybe thankfully entered their mind yet as something that should be done on IMTs. And so we don't do it. And then the third thing to keep in mind is, none of the tests are perfect. So fish can miss some of the fusions depending on exactly where the partner is, and depending on what kind of sequencing you're doing. If the coverage isn't great on ALK, then you might also not pick it up, and so you might be left with a situation of something that really looks like an IMT with positive ALK staining, but your confirmatory test didn't detect it. And so honestly, we would still end up calling it an IMT if we think it looked like one. And so, maybe in 6 months or a year, we'll start doing sequencing on all of them, but at least here, we don't right now.
Yeah, David, that was a question from one of our people in the audience. Do you, once you have ALK positivity, what do you do? So I think you've answered that. They've also asked another part.
Angelica, I just point out, I don't know if that's the right way to approach it. I'm just explaining what we do.
But that's what you're doing. And they've asked an interesting question, which I guess this applies to everything when we do ALK and it's positive. Is there a scenario where something stains with ALK and it is not an IMT?
I think, first of all, if you had, to answer their first question, if you had a leiomyoma or what you thought was a leiomyoma that stained with ALK, I think you should really seriously consider the possibility that you're looking at an IMT with leiomyoma-like areas. And I'm not, perhaps someone else knows, but I'm not exactly sure about the sensitivity and specificity of ALK with tumors. And can you, if you can see stain in other tumors, but personally, I wouldn't order ALK if I didn't think that the morphology was potentially consistent with an IMT.
And David, if you see IMT on myomectomy, what would they do at Brigham?
So to be honest, I don't recall that happening, but I think they would probably just follow the patient, assuming they're not postmenopausal and might have some other indication for, a hysterectomy, but I think they'd follow.
Sharon,
and I think the pathology community might be aware of that risk stratification that was brought up in histopathology, but a clinician, has never mentioned it to us.
I looked up a immunoquery to see whether leiomyomas can exhibit or can express ALK. And according to immunoquery, it could be just a focal expression, but not diffuse expression as in the case I've shown. And also from our own experience, we do see sometimes the very weak and focal ALK expression in pregnancy-associated leiomyomas. But other than that, it's quite specific based on immunoquery.
Great. All right. David, how about you go ahead with your case? Thank you, Dr. Nofek-Moses and Dr. Paliga. That was great.
So this is a trio of 3 cases. I kind of squeezed 3 into one. And hopefully Anjelica and Anna are okay with that. So the first, and you'll see that I promise they're tied together. So the first one is a 51-year-old woman with abnormal bleeding, and we have an endometrial biopsy. So at low power, you can see it's a cellular neoplasm, and I just indicated some thick-walled vessels because just like Dr. Paliga, when I see thick-walled vessels, I think that it might be a smooth muscle tumor. So just wanted to point out that those were here. And elsewhere, some areas of the tumor didn't have the thick-walled vessels, but they were composed of this kind of patternless arrangement of cells with smaller vessels. And if we go up onto higher power, you'll see there might even be two populations of cells. The ones that I've highlighted with the blue arrow are larger epithelioid cells, and then they're kind of surrounded by these smaller cells. And so an immunohistochemical panel was done, as you might suspect. The tumor was positive for ER, negative for CD10. The Desmond, which unfortunately I don't have to show you, was diffusely positive, and for that reason Cal Desmond was done, which was negative here. And cyclin D1 was also performed, and it shows strong staining in those larger epithelioid cells. And I think based on the morphology with the thick-walled vessels, and perhaps the Desmond expression, you might wonder about a smooth muscle tumor. With the ER expression and the relatively bland monomorphic cells, you might wonder about a low-grade endometrial stromal sarcoma. And for what it's worth, the mitotic activity in this tumor was quite low. It was only 3/10. And then finally, with the cyclin D1 expression in those larger epithelioid cells, you might wonder about a high-grade endometrial stromal sarcoma. And for this case, DNA sequencing was performed, and indeed it did show a YWHAE NUT M2B fusion. And so this was a high-grade endometrial stromal sarcoma. And I included this for a couple of reasons. One is because I think it's unusual to see that really strong and diffuse ER expression in high-grade ESS. You typically think of them as being negative for CD10, ER, and PR in the areas that are higher grade, but it did have that strong cyclin D1 expression in the larger cells. And so I think this could have been called potentially a smooth muscle tumor or a low-grade ESS, but ultimately this is a high-grade ESS. That negative CD10 should really dissuade you from calling it a low-grade ESS, because CD10 is positive in like 95% of low-grade ESSs, and it would be very unusual for that to be negative. Here's a related case, a hysterectomy specimen in a 50-year-old, and it was sent in because someone asked whether or not this could be a high-grade endometrial stromal sarcoma, and they wondered this because they did a cyclin D1, and you can see it's strong and diffuse in the tumor cells. But in fact, an MLH1 that was done shows loss of expression, and so this is an undifferentiated carcinoma. And I think this case is nice because when you have a malignant epithelioid neoplasm in the uterus, you should be aware that, number one, cyclin D1 is not specific for high-grade endometrial stromal sarcomas, and cyclin D1 expression has been reported in undifferentiated carcinomas, so you should be aware of that pitfall. But the other thing is, for undifferentiated carcinomas, you don't need fancy molecular testing a lot of the time. If you have access to mismatch repair immunohistochemistry, that can really be helpful diagnostically. And similarly, if you have switch SNF proteins like SMARCA4, SMARCB1, or ARID1B, those can also be very helpful to diagnose an undifferentiated carcinoma in a tumor that otherwise doesn't appear to express any lineage-specific markers. And then the final related case is a 46-year-old with a uterine mass. Here you can see this very blue tumor that has, in some parts, maybe more tongue-like, in other areas more destructive, permeative myoinvasion, but the pattern of invasion, I think, is reminiscent of a stromal sarcoma. And on higher power, the cytomorphology, I think, is also in keeping with potentially a high-grade ESS. The original pathologist also thought this was probably a high-grade ESS based on the pattern of infiltration and the cytomorphology. And so it was negative for CD10, ER, and PR, which totally fits with high-grade ESS. And cyclin D1 was done, which was positive. And so this was actually signed out as most consistent with a high-grade ESS harboring a YWHAE NUT M2 fusion, just based on the morphology and the IHC without any molecular testing. And that was fine until the patient recurred and the tumor was actually sent for DNA sequencing, at which point an EWSR1 Fly1 fusion was detected. And so this is a case of a Ewing sarcoma of the uterus that had been misdiagnosed as a high-grade endometrial stromal sarcoma. And so in this last case, what potentially led you down the garden path? So if we look at a real case of a high-grade ESS that does actually harbor the fusion, you'll see the cyclin D1 is really strong and diffuse and intense. And in the case of Ewing sarcoma, granted there was positive staining, but it doesn't exhibit the strong and diffuse staining that's really typical of high-grade ESSs. And so what do I hope to show you with these three related cases? Well, one is that diffuse cyclin D1 in the uterus is not specific for high-grade ESS, and it can be seen in undifferentiated carcinomas and other sarcomas. You can see desmin expression in both high-grade and low-grade endometrial stromal sarcomas as well. Different people will give you different opinions about this. My opinion is that if you see something that looks like a low-grade ESS and it stains like it, then personally I think it's okay to diagnose it on morphology and IHC. But high-grade ESSs should probably be confirmed with either FISH or DNA and RNA sequencing, and I think those second two cases I showed you might highlight why calling them on H&E or just with IHC can lead to some problems. If you have access to MMR or switch SNF proteins, I'd encourage you to use them when you're presented with what looks to be like a malignant epithelioid neoplasm of the uterus that's negative for keratin and negative for S100 and negative for desmin, and you don't know what it is, because often that can really direct you to an undifferentiated carcinoma. And finally, not just with respect to these cases, but in general, if you ever see something that looks a little bit funny or doesn't fit into any GYN specific box, just think what you might call it if you saw it elsewhere, and think if there's anything else it could be, because things like Ewing sarcoma or solitary fibrous tumors do occasionally happen in the GYN tract, and it's just important to keep that in mind when you're looking at cases.
David, I like your point. I like it all, but I like your point about the MMR IHC as a diagnostic tool, because often I think many times, people think about it as its purpose, which it has other purposes, of course, but its purpose to screen for Lynch syndrome. And of course it functions to do that, but we can utilize it in this scenario and all sorts of other scenarios to help us make the right diagnosis. So that's a really great tip for everybody.
Yeah, that's right. And you can really avoid molecular testing in cases that otherwise would be difficult to classify, and it lets you sign them out faster and more, inexpensively. And undifferentiated carcinomas tend to be aggressive, and so it can also serve a therapeutic purpose as well. And the clinicians may be interested in knowing that as well, and you can tell them, because the patients often present at high stage.
Yeah, for sure. And another question, which I think is well, these are all rare. All these things are rare, right? But if you're signing out GYN, including in the community, stuff like this is going to come up on curettings and stuff like that. And so what kind of advice do you have for everybody, but particularly people in the community, about kind of coming down on a reasonable diagnosis that gets a patient to the appropriate, next step in their management, A, and then B, you suggested for if you're thinking of high-grade ESS, that's a situation where you should do molecular. Is there any other kind of tips for when you would say, molecular needs to be done on this case?
I'm just trying to think of some broad advice. If you're really unsure about a diagnosis, or it's the first time you've diagnosed something, I would suggest sending it out for outside consultation. And I suspect in Ontario, frequently, if it's seen in the community place, it may go to a larger center for oncologic surgery. Anyways, But my personal view is that, anything where you're considering a high-grade ESS, whether it's a B core or a YFAM, you should send it for molecular testing. And if you have, malignant epithelioid neoplasm, oftentimes, as I've mentioned, people will think about Carradines and Desmond and ruling out melanoma or hematolymphoid, but they don't consider how some of those other things like mismatch repair immunohistochemistry can be diagnostically useful. And frequently, at least for an initial triage of how the patient's handled, the clinician may not need a final diagnosis. Oftentimes it can be deferred to the hysterectomy specimen. And so it might be helpful to have a conversation with the clinician to know whether or not a descriptive diagnosis would be sufficient to help guide patient management, because we've certainly seen cases where a biopsy is sent in from the outside, and by the time it gets here and we do stains and we work it up and we sign it out, the patient's care has been delayed by several weeks when really it just needed to be communicated that the patient needed a hysterectomy. And often, by the time you get more tissue, that can help clarify the diagnosis as well. The classic example would be for undifferentiated carcinomas on the hysterectomy specimen, you may see a well-differentiated component, and that would tip you off to the diagnosis of dedifferentiated carcinoma.
Anna, anything, or we'll move on to Dr. Yang, who's going to present his case.
Okay, great. Thanks. Thanks for the opportunity to present this case. Yeah, my name's Howard Yang. I'm one of the pathologists at Markham Stouffville Hospital. And just want to share an interesting case that I encountered and finalized within the past couple of weeks. So this case is a 46-year-old female with a history of a fibroid with worsening menorrhagia. Past medical history is just notable for 2 prior C-sections in an IUD. And ultrasound shows a 10.3 centimeter intramural fibroid, according to the report. And don't have too much other history as to, how long this lesion was around for or anything. But eventually the patient was consulted for the possibility of uterine artery embolization or resection, and ultimately opted for resection. So in pathology, we received a total hysterectomy with bilateral salpingectomy, which showed an intact specimen showing an intramural tan white nodule whorl appearance measuring 10.5 centimeters, which was compressing the endometrial cavity. Cervix was normal and fallopian tubes were normal, and we sampled it at approximately 1 section per centimeter. So at this point in the history, it's not very remarkable, and it's something that we see, pretty often, pretty usual. So on histology, I've shown one area here as successfully, higher magnification, showing a rather high cellularity spindle lesion. You can see that it's sort of in a short vesicular, maybe almost herringbone-like architecture. And on high magnification, you can see that the nuclei are overall pretty bland without significant nuclear pleomorphism or mitotic activity. What was interesting, though, was another area, which I've shown on the bottom here, has an area which is, you can see on lower power, is kind of more eosinophilic and lower cellularity here. You still see some of this, the similar vesicular architecture, and again, very bland nuclei within an eosinophilic background. And perhaps if you take each of these images in isolation, they might not be terribly unusual for a leiomyoma at a cursory glance. But what was interesting in this case was a striking heterogeneity within these 2 areas. And you can see even in the lower image, the sharp demarcation between areas with high cellularity and lower cellularity here. And this pattern was actually repeating throughout many of the sections, interestingly. And I'll show another image here. I apologize for the poor quality section here, but you can see that there's areas of high cellularity, and then suddenly you have this sharp demarcation with these nodules with this similar low cellularity regions. And there were some large thick-walled vessels, as well as scattered smaller muscular arterioles in a patchy fashion throughout the lesion as well. Some other things, no necrosis was identified, and mitotic activity was quite low, less than 1 per 10 hyperpower fields on average. So at this point, I did some immunohistochemistry. And just to show, the top row is the higher cellularity areas, and the bottom is the lower cellularity eosinophilic areas. And you can see SMA is kind of more strongly positive here, and on the lower picture, there's still some positivity, but Desmin is negative. Cal-Desmin, a little bit of patchy staining in the higher cellularity areas, and negative here. And CD10 was kind of the opposite, where the higher cellularity areas were a bit patchy, but quite diffusely strong within the lower cellularity areas. And ER was diffusely positive throughout the entire lesion. I also performed SMMS, which was similar to Cal-Desmin. Ki-67 was 1 to 5% throughout the lesion, and cyclin D1 was negative. So kind of unusual features here. It's not quite showing very good smooth muscle markers, and some, almost like endometrial stromal type expression here. One thing I did is I went back to the gross, and I apologize. This would have been nicer with the whole slide, with the capability of whole slide imaging, but I basically just took pictures of my slides just to show that you can see that most of the tumor, the slides on the left, are pretty well circumscribed. But when I went back and finally sectioned some areas, you can see that there's actually indeed some focally infiltrative areas. And the right is just a picture of that infiltrative area, which measured almost 3 millimeters in terms of the extent of infiltration. So after reviewing this with my colleagues, we weren't entirely sure what we were dealing with. There seemed to be some ambiguous features that we felt defied definitive classification. We felt that we might be dealing with some sort of endometrial stromal lesion, maybe along the spectrum of an endometrial stromal nodule to low-grade ESS. But we felt that we needed molecular confirmation. So I simply signed it out as endometrial stromal lesion and sent it for molecular testing. And what I received was a rather interesting result and an interesting learning experience. It showed a CAT6B CANS SL1 gene fusion. I'm not sure whether I'm pronouncing that correctly, but this was definitely a new finding for me. And this essentially led to a final diagnosis of uterine sarcoma with CAT6B CAN SL1 gene fusion. So from what I can find in literature, this is a newly described tumor, not currently recognized in the WHO classification. It was first identified in 2015 and characterized by a fusion in CAT6B or CAT6A, but most of them seem to be with the CAT6B gene. And a total of 32 cases have been reported in the literature to date, of which in the past, I believe 2 years, there have been just a couple papers showing a broader, larger studies on these tumors. And I see Dr. Kolin, our guest speaker today, is a part of one of the studies here. And these tumors initially, when this fusion was identified, was initially described as a benign leiomyoma. But the more recent studies have shown more aggressive behavior, which have also shown higher recurrence rate and even mortality rate. I believe it was just above 25% in one paper for both recurrence and mortality. And some of the original diagnoses prior to the identification of this, these included leiomyosarcomas to low-grade endometrial sarcoma with atypical features. And based on gene expression analysis from one of the latest papers, they show that all of these lesions clustered together, supporting that it's a distinct entity. And that they were distinct from some of the mimickers like leiomyosarcoma, but actually showed some close relationship in expression to low-grade endometrial stromal sarcoma and endometrial stromal nodule. The median age at diagnosis was 47.5 years, essentially non-specific symptoms, and typically involved the uterine corpus, but rarely there was a extrauterine presentation as well. So in the interest of time, I haven't included much more details, but this latest paper proposed some unifying features that might suggest this etiology, and an algorithm that I've just kind of shown here, interestingly, which essentially describes what this neoplasm shows hybrid features between endometrial stromal tumor and smooth muscle tumors. You can see some of these look fairly similar to the images in my case. And at the same time, we have an immunohistochemical feature which shows the ER diffusely positive, but otherwise heterogeneous or inconsistent expression of both endometrial stromal sarcoma and smooth muscle markers, and finally confirmation by molecular testing. So it's still early in the course of my case, the patient's clinical course, so I don't have much follow-up, but interested to hear about other people's experiences with this lesion as well. That's my talk.
I can't say to the best of my knowledge I've ever seen this, but Howard, as you said, lucky for us, David has.
Yeah.
Yeah, difficult. I mean, these things, I mean, David, this is an area of interest of yours. Like, you get something that looks like it could be something that you know about, but it's a bit off, and then the IHC is a bit off, and there you go, it ends up being something new. So any tips on this in your experience?
Well, I can say a few things. I don't know how helpful any of it will be, but I can add a few things. One is that Howard described the case really nicely, and I think it follows how people feel about these cases in general, because you look at it and you're not really sure if it's smooth muscle or stromal, and then you try to stain it, and the IHC may not be totally helpful either. And in fact, when you think about new entities in pathology, sometimes it's because someone who's seen a lot of cases will be like, oh, this case looks like the case I had last year, and I think 3 years ago I might have had another case, and you pull them and you look at them and you're like, oh, all of these things look really similar, and I think this is the same entity. Having said that, I think this is different because, as far as I know, at least in the HASP paper, I think all of those cases came up and were discovered because people didn't really know what these things were. They were all signed out as either funny-looking endometrial stromal sarcomas or unusual smooth muscle tumors, and they ended up being sent for sequencing, and they were all found to harbor the same fusion. And when you look at the images, there might be some morphologic overlap, but there's no real great diagnostic features either by morphology or specific immunohistochemistry. And for that reason, I think they're a very frustrating tumor because, I'll be signing out with fellows frequently and I'll say, oh, I think this is probably a stromal sarcoma, or I think it's probably a smooth muscle tumor. And they'll say, well, how do you know it's not a KAT6A KNSL1 tumor? And then I'll say, well, I don't really know for sure. Maybe it could be. And so I do find them frustrating, and I can add a couple of related points. One is they're extremely rare. I've sequenced a bunch of uterine stromal sarcomas, and it's in like maybe less than 1% of tumors that are difficult to classify. So I think the chances of you missing one are really uncommon. And then the flip side is I don't think the clinicians will know how to treat them very specifically. So if you happen to misdiagnose it as an ESS, for example, the clinicians would probably be most interested in the ER/PR status and treat based on that. Of course, it's interesting to accumulate more cases and to see what the natural history of these tumors is like, and maybe to have some kind of targeted therapy, but we're just not there yet. And I find them very, very diagnostically challenging, and I have no clue how many I've potentially missed, but luckily I think they're uncommon. Oh, and then sorry, I can just Howard mentioned the gene expression profiling. We have I was part of a series that was presented at USCAP a couple of years ago that I don't think has been published yet, that looks at methylation analysis. And with the methylation analysis too, they form a cluster that's definitely distinct from low-grade ESS and smooth muscle tumors and high-grade ESS. So they do really seem to be their own distinct entity, and not, for example, like some unusual low-grade ESS.
Mhm. Anna, anything, or we'll go for David?
David, generally ER, we used to think sort of helpful stain for even smooth muscle tumors. What is your take on ER positivity, like diffuse positivity in the mesenchymal neoplasms?
I mean, it can be seen in many different types of mesenchymal neoplasms, and that first case I presented of the high-grade ESS with diffuse ER positivity is the exception rather than the rule. So diagnostically, it can be helpful, I think, for low-grade versus high-grade ESS, but also clinicians are very frequently interested in it for both smooth muscle tumors and stromal sarcomas in terms of how they're approached clinically.
All right. Thanks, Howard. We'll let David do his next case.
Great. Okay, so for case 4, the first case was a little bit wacky, but this one I think is more bread and butter for maybe community pathologists. So this is a case of a 32-year-old woman with an endometrial polyp. Some areas of the polyp have very myomatous stroma, and it imparts a cellularity around some of the endometrial glands that you see. In other areas, you can still see the myomatous stroma, but the stroma is expanded somewhat, and some of the endometrial glands start to have a funny appearance that look like animal crackers, or see what you want in them, but they do start to have funny shapes. And elsewhere, the stroma expands, and it imparts almost like a phyloidiform architecture to some of these endometrial glands. And on higher power, there might be a vague condensation underneath the glands, but the cells lack significant atypia. And so the question for a case like this is, is this an Mullerian adenosarcoma, or is it something less? And so Brooke Howitt wrote a series of 29 funny looking polyps from the endometrium and cervix, and wondered what the diagnostic threshold might be and how they behave. And of the unusual polyps, there was follow-up on 28 of them, and the vast majority were benign, 27 of 28, and one patient died from something else. A quarter of the patients had hysterectomy, and they were able to definitively exclude that something else was going on. And many were followed by biopsy or just followed clinically. And so if you have an unusual looking polyp where you wonder about an adenosarcoma, what are some things that could talk you down from the ledge. So one would be if there's just partial involvement of the polyp. The other one would be if the phylloides architecture is not well developed. And the third one would be if the cuffing is just pretty vague. And so here's an example where it's just partially involving the polyp. You can see what looks like normal endocervical glands on the top and on the right, and in the middle, it has that area of increased cellularity with the compressed glands. Here's another one where the cuffing is just very loose and vague, and the cells that line it lack the atypia and mitotic activity that you would see in an adenosarcoma. And so I bring this case up just because we see these funny looking endometrial or endocervical polyps occasionally. And really the point is not to overcall adenosarcoma in these polyps. If you come across one and you're concerned about the possibility of one, but you don't think it's diagnostic of an adenosarcoma, you could sign it out as an endometrial polyp with unusual features or an atypical uterine polyp or something to that effect, with a comment that remarks on those unusual features, but just to say that it's not diagnostic of an adenosarcoma and suggest a follow-up biopsy perhaps in several months. And this is especially an issue in younger patients where a diagnosis of an adenosarcoma could trigger a hysterectomy, when really these funny looking polyps are associated with a benign course. Interestingly, I didn't include the reference here, but David Chapel did some molecular work on these atypical polyps, and they show molecular features that are intermediate to those of benign endometrial polyps and uterine adenosarcomas, suggesting that they are somewhere on the spectrum, but just associated with a benign course. And so I just threw this in because it's something that I think people see on a day-to-day basis, and it's helpful to know how to approach.
Yeah, I think, David, you focused on not overcalling adenosarcoma, right? Which is very important. What are the implications of underdiagnosing adenosarcoma?
Yeah, so the most adenosarcomas don't have sarcomatous overgrowth, and they don't have myometrial invasion, and they don't have lymphobascular invasion. And those adenosarcomas are associated with a relatively benign course. They're usually resected, and sometimes patients will get hysterectomies, but those tend to be okay. And so, having said that, of course, there's the opposite end of the spectrum. Like you wrote about the P53 mutant Mullerian adenosarcomas that are morphologically high grade and they have sarcomatous overgrowth, and those are like definitely bad news and malignant. But I don't think people would mistake an atypical or an unusual uterine polyp with one of those. And I think the out, so to speak, is that if you're not 100% sure that it's benign, you can you can just suggest a follow-up biopsy, and they'll be brought back just to make sure that it hasn't recurred.
Yeah, I think that's very reasonable and practical, because this does come up, right? Like you said, you're seeing a lot of curettings. This is going to come up for sure.
Yeah.
Anna, anything you'd like to add?
No, I completely agree. And also with the cervical biopsies, sometimes we get a similar situation with the cervical polyps, and sometimes you don't know where even they're coming from. And I think we're trying now to be more on the benign side versus a few years ago. Thank you, David.
Yeah, I definitely think the diagnostic threshold has shifted. As part of another project, I reviewed things that had been called adenosarcomas like 20 or 30 years ago. And I looked at some of them and I'm like, I don't think people would call that an adenosarcoma today. I think it's probably a funny looking endometrial polyp, but things shift over time.
Yeah, for sure. Okay, awesome, thanks. Now we're gonna have Dr. Sylvia Papp. We're gonna change gears a little bit.
Thank you so much, Anjelica, and hi, David. It's so nice to see you. David and I finished residency together, and Anjelica. So let me see, I'm just gonna share this. I will try to make this brief. I see we're running out of time. So thank you so much. My name is Sylvia Papp, and I'm a pathologist at the Peterborough Regional Health Center, where we do general sign out. And I've been here for about 5.5 years. And I would like to share this interesting case with you. Not really diagnostically challenging, but more interesting because of the implications for the patient. So this is a 50-year-old female with a history of multiple sclerosis, hypertension, and she did have a hysterectomy with a bilateral salpingectomy in 2021, during which that surgery they noted significant intra-abdominal adhesions, and it was a benign hysterectomy. They just noted endometriosis of the right fallopian tube. Now for this, she presented with a lower GI bleed. So she presented with bright red blood, passing clots, and abdominal discomfort. They found no hemorrhoids or fissures to account for this blood. So they did a CT scan, which showed a mass that was about 5 centimeters, and it was inseparable from the wall of the sigmoid. And there was no evidence of any metastatic disease. They did actually a sigmoidoscopy, and they noticed marked narrowing at around the 30 centimeter mark. And this colonoscopy image shows what the clinician saw at the time, which was remarkable only for blood clot. They did biopsy it, and the biopsy actually only just showed necroinflammatory debris and some blood clot. So they went on to do a rectal sigmoid resection, and there was this hemorrhagic appearing polypoid lesion in the upper rectum, which measured about 2.5 centimeters. There were no lesions anywhere else in the specimen. And there it is again on cut section. You can see this nodular area involving the bowel wall and popping up into the bowel lumen as this hemorrhagic appearing polypoid lesion. And this is what it looked like. I apologize for some of these bad images. It was hard to get it all into one, even at low power. So you can see up here, the colorectal mucosa, it was pristine, and here lower down in the bowel wall, we see something very familiar looking and not so ominous. So I was relieved to see that. There's some more pictures on low power. You can see this polypoid lesion, and I think this is fitting so well with Dave's adenosarcoma, because I was really paranoid that I was missing something like that, but I can assure you there was no Phyllodes architecture, no mitotic activity in the stroma. It was very, very bland appearing glands with nice stroma. The glands have, like a clean, smooth lumen. So there's really, really nothing atypical. So I was happy for this lady that she had endometriosis. And this is a mesenteric nodule. You can also see sort of classical endometrial glands with their stroma surrounding. And, just being paranoid, and I QA'd, of course, and just did some confirmatory immuno. So the ER you can see strong in the glands and stroma, the vimentin as well, and the PAX8. So interestingly, as I was browsing some more of these nodules, I came across this sort of little area within an area of a neurovascular bundle. And I thought, oh, that looks really suspicious for vascular involvement. So I did an elastic trichrome and an ERG. The ERG wasn't super amazing, so I didn't want to show it, but we were fairly convinced on this elastic trichrome that this was sitting in this vein here that's nicely adjacent to this artery, and there's some peripheral nerves there. And on higher power, I could convince myself that I did see a tunica media with some smooth muscles, and then the tunica adventitia, and you can see some broken elastin fibers. So we were pretty convinced that this did indeed show vascular involvement by the endometriosis. So in my final pathology report, I signed it out as extensive endometriosis involving the upper rectum, forming this mass. That was about 2.4 centimeters. Interestingly, so there were 11 benign lymph nodes sampled. None of them showed any evidence of endometriosis, but there was venous involvement by the endometriosis, which I did explain in a comment, did not signify malignancy. And so just to give you, so this was about a year ago, actually, it was in April of last year that she had the surgery. She continues to have abdominal pain and bloating. They did a very recent CT abdo-pelvis, which was clear and with no other findings to account for the patient's symptoms of her current abdominal pain. So this kind of leads me into my discussion about endometriosis. So these are just, the three main theories of spread: retrograde menstruation, metaplasia, and lymphovascular spread. I just put this up because, as we all know, endometriosis can come in different shapes and forms, and it can be extensive or not so extensive. It could be just superficial peritoneal involvement. It could be more deeper, penetrating to depths greater than 5 millimeters and associated with scarring and extensive adhesions. Of course, the ovarian endometriomas and extrapelvic occurrences. They can invade the colon, bladder, etc. But really, what I wanted to focus this quick discussion around is, so this poor woman, had to have now a rectal sigmoid resection for a benign entity. So it's, that's a massive surgery to have for such a condition. And, many women, I guess, perhaps maybe even silently suffer from this disease, which is what I wanted to maybe discuss is, why are some women more, prone to even having endometriosis than other women? Why are some women's endometriosis so extensive and even invasive as opposed to others? So, across my readings and review articles, they discuss kind of three major things to influence, I guess, how endometriosis will settle or take presence in a woman. So this can include the woman's endogenous milieu, so hormonal, inflammatory, fibrinolytic environment, molecular subphenotypes, is it epigenetic, transcriptome, things like that. As well, it was very interesting that there's many coexisting conditions have been described with endometriosis, including, GI, GU, things like, adenomyosis and fibroids. Then there's chronic pain syndromes like fibromyalgia, mental health, such as anxiety, and interestingly, autoimmune disorders and immunologic disorders, including multiple sclerosis, was listed as being associated with endometriosis. Not necessarily, causative, but just it was observed that these can be seen with it. And interestingly, this patient does in fact have multiple sclerosis, which I thought was very interesting. So really, this just brings me to my summary slide of, endometriosis really, I think maybe it's taken for granted, but it really is, it can cause like great disease burden. Some of these women can have chronic pelvic pain for life, infertility, and it can affect their overall quality of life, even with, surgical or medical treatments. Some of them may become refractory. And very interestingly, they can become sensitized to this pain. So it's called like a nociplastic pain process, where your nociceptors kind of are signaling that you're in pain, even though there's no actual or threatened tissue damage. And that really you've just become, I guess, sensitized now to this pain, and even medical or surgical treatments will no longer be helpful in that sense. So with that, I just wanted to show my references, and thank you so much. And I hope to hear your thoughts, Dave, and others.
David, do you have any comments?
Yeah, I mean, Sylvia, okay, so first of all, Sylvia, it's great to see you again, but also it's great that you mentioned the adenosarcoma, because I think with polypoid or mass-forming endometriosis, adenosarcoma is like definitely in the differential, and I've definitely seen cases of polypoid endometriosis overcalled as adenosarcoma. I think people get distracted by the fact that it might form a mass, and there's a little bit of architectural irregularity, and then you can kind of go down the tubes that way. So I totally think it's in the differential, and you should be aware that it's not overcalled. And of course, adenosarcomas can, in theory, arise from endometriosis or in the pelvis. So it's a real diagnostic consideration, but just be careful you don't overcall it.
David, what about your experience with atypical endometriosis? and atypical hyperplasia in endometriosis, and what that means, and what we're supposed to do about it, and what clinicians are supposed to do about it.
Yeah, so I don't know if there's really widely accepted criteria for atypical endometriosis, and I think people probably apply that term to a few different kinds of lesions. One would be where you see like what looks like normal endometriosis, but when you go up on higher power, the cells look atypical or reactive, and you're concerned that they're somehow dysplastic because of what they look like. I think oftentimes with endometriosis, because it's always surrounded by blood and reactive oxygen species and stuff like that, I think often endometriosis can just kind of look angry sometimes. And so personally, if I see reactive atypical looking epithelium lining what is otherwise like a normal endometriotic cyst, I don't know if I'd necessarily diagnose it as atypical endometriosis. The second situation is when you actually see glandular crowding or architectural complexity in areas of endometriosis, and I think that's a little bit more worrisome. If you see things that look like what you'd think about as like an EIN or an atypical hyperplasia, if it was in the endometrium or focal cribiforming or stuff like that, then I'd note that and bring it up. But the idea of atypical endometriosis is a little bit ambiguous, I think.
Yeah, for sure. I think I think of it like that. Atypical hyperplasia or carcinoma and endometriosis is one thing, and then the atypical endometriosis, it's almost like you're going into like clear cell, almost like that type of
Right.
atypia, and you're right, it's nebulous and difficult and challenging for sure. Okay. Thank you, Sylvia. That was awesome. And we're gonna end. We're just a bit over time, but Dr. Kolin has agreed to just do his last cases. So if you're able to stay, please do.
All right. So case 5. This is a 55-year-old female who had a hysterectomy for what the clinician thought was fibroids. Grossly, there was a well-circumscribed intramural 6-centimeter mass. You can see it's tan, and it appears to be well circumscribed grossly. And sure enough, microscopically, it also appears to be well circumscribed. I think at low power, you might even appreciate that it has some interesting architecture to it, with perhaps some areas of nesting or nodular growth. On higher power, you can see some areas look very trabecular, like on the left, whereas other areas might appear more sheet-like or solid on the right. And on higher power, cells were ovoid with nuclear grooves. The immunohistochemical profile of this tumor was interesting in that it expressed positivity for keratins, SMA. There's a little bit of inhibin expression, and it was also positive for calretinin and CD99. As you might expect at this point, this is an example of a uterine tumor resembling an ovarian sex cord tumor, or a utrosk. The description of these goes back to 1976 in a paper by Clement and Scully, where they described 2 different types of uterine tumors with sex cord differentiation. The first were tumors that looked like stromal sarcomas with a little bit of sex cord elements, and these we now appreciate to be low-grade endometrial stromal sarcomas with focal sex cord differentiation. And then the other group, they said predominant or exclusive, and it wasn't really clear how predominant was, but in any event, most of the tumor looked like it had sex cord differentiation, and these are what we now appreciate to be utrosks. There had been some prior molecular studies that didn't identify JASF1 or SUS1-2 fusions in them. There were no PAF1 rearrangements, which is the gene that's frequently involved with stromal sarcomas that have sex cord differentiation, and they also did not harbor FOXL2 or DICER1 mutations, which are seen in some sex cord stromal tumors of the ovary. And then about 5 years ago, in an AJSP paper, Brendan Dixon at Mount Sinai Hospital showed that they were found to harbor recurrent ESR1 and GREB1 fusions with partners of NCOA 1, 2, or 3. And then Emily Goebel, who was a prior fellow here and who's now at University of Western Ontario, or I think it's not called University of Western Ontario anymore. That just shows you how long I've been out of Canada. But in any case, Emily's in London now, but she did this amazing work where she looked at over 20 utrosks and found that indeed the vast majority of them harbor these recurrent fusions, and others like Anjelica have shown that sometimes you get other bizarre fusions in them, like this GTF2-1A NCOA2 fusion. As you might imagine, these tumors have a really wide differential diagnosis, including a low-grade ESS with sex-scored differentiation, adenosarcomas with sex-scored elements, which you can see sometimes, adenocarcinomas with sex-scored differentiation. And then just based maybe more on the IHC than the morphology, but you might wonder about adenomatoid tumors or pacomas or smooth muscle tumors because they express those markers as well. There's also a question of whether or not there's something called a GREB uterine sarcoma, which I won't go into, but that's also in theory in the differential diagnosis. And so, when you have a tumor like this that's keratin positive and ER positive, you might wonder if it's some kind of Mullerian carcinoma because it looks like it's really forming these glands. But RNA sequencing, for this particular case, identified an ESR1 NCOA2 fusion, and so it is indeed a utrosk. And just a few points regarding these tumors. They're usually well circumscribed grossly. Microscopically around the periphery, you may notice that there's some permeation into the surrounding myometrium, and whether or not that's real infiltration or not, I think is up for debate, but they do sometimes creep around the benign smooth muscle. And they're really striking for both the architectural variability that they have as well as the immunohistochemical variability. And so they're you can see solid sheets, cords, trabeculae, or even sertoli form growth sometimes. And they'll stain for a wide variety of markers. So broad spectrum keratins are positive, sex-scored markers like inhibin, calretinin, melin A, CD56, which is horribly nonspecific, but also positive in these tumors, smooth muscle markers like SMA and Desmond, and hormone receptors as well. These are generally regarded as potentially malignant. There was one series published by Glenn McCluggage that showed a recurrence rate of up to 23%. I think that's probably a little bit high, and there might have been some referral bias in the tumors were sent to him because they recurred. It's probably lower than that. That would be the upper limit. And there have been several papers that have looked at what could potentially be predictive of outcome. And while there's no widely accepted system to predict how these might behave, people have suggested that tumors over 5 centimeters, those with more than 3 mitoses per 10 high power fields, or significant cytologic atypia, infiltrative borders, necrosis, things that you might typically imagine could be associated with a worse prognosis. There's also some suggestion that the fusion partner may be predictive of outcome in that the GREB1 tumors may be more aggressive than the ESR1 tumors. And some case series have shown that those with rhabdoid morphology may be more likely to recur. That was all I had to say about utrosk. Do you want me to go into the next case, Anjelica, or pause for any questions or discussion?
I think maybe the next case, David, would be
Sure.
good.
Okay, so we are moving on to my final case. This is a 30-year-old female. She presented with an enlarged vascular friable 4-centimeter cervical mass, and she had a total abdominal hysterectomy and bilateral salpingectomy with omentectomy. Sections of the hysterectomy showed a mass that was centered around the cervix, as you can see grossly on the left and microscopically on the right. It was tan white and seemed to be ill-defined. On higher power, you can appreciate that the tumor is composed of these haphazardly arranged ovoid to spindled cells, which permeate around the benign endocervical glands. And in some areas, there was more pronounced cytologic atypia characterized by these hyperchromatic enlarged cells with variably prominent nucleoli. The tumor also had two unusual histologic features, which I wanted to bring to your attention. One are these really prominent hyalinized vessels, which are pretty striking, I think. And then elsewhere, you can see nuclear pseudoinclusions right in the dead center of the image here. And so based on the clinical presentation and the morphology, it was thought that this could represent an NTRK rearranged uterine sarcoma, and pan-Trk IHC was performed, which was positive. And then this was confirmed with RNA sequencing, which identified an NTRK1 fusion. So these are relatively recently recognized entity. They tend to affect younger women, but there can be a very broad age range between 13 years and 69 years. The vast majority arise in the cervix, but occasionally they can occur in the uterine corpus as well. NTRK1 rearrangements are by far the most common, followed by NTRK3, and then very, very rarely NTRK2. These can recur about 20% of cases, and unfortunately some patients will die from disease. The mainstay of treatment is surgery. And then for recurrent or metastatic disease, patients can be treated with TRK inhibitors like larotrectinib or entrectinib, and it's for that reason that it's important to identify these tumors. The pan-Trk IHC that I showed was pretty sensitive and specific. In this large series that was published in Histopathology, they found it was positive in 92% of NTRK sarcomas, whereas only 2.4% of other uterine sarcomas stained. And so it's a really a pretty good screening test. And you should really consider this diagnosis in a spindle cell tumor that occurs in the cervix, if it's Desmond and ERPR negative. So, smooth muscle tumors will be a lot of the spindly things you see in the cervix. And if it's negative for Desmond, ER, and PR, then you should really consider the possibility that it could be an NTRK rearranged sarcoma. Some papers will talk about CD34 and S100 positivity, and it's not wrong to order those stains, but the expression can sometimes be patchy. And so especially if you have a small biopsy, if those are negative, I don't know if I would let that dissuade you from considering this diagnosis. Because the NTRK IHC isn't perfectly sensitive or specific, molecular confirmation is usually suggested for definitive diagnosis. We had a prior fellow, Danielle Costigan, write up a series of these cases and identify some prognostic features, and she found that a mitotic index of over 8, LVI, necrosis, and those with NTRK3 fusions might behave in a more aggressive manner than tumors that lack those features. Obviously, there's kind of a broad differential, which we don't get into, but smooth muscle tumors, spindled melanomas or spindled carcinomas, solitary fibrous tumors or MPNSTs are all kind of in this group of tumors. But the NTRK ones are really important to correctly identify because of the targeted therapy that's available for the patients. And that was all I had to say about the NTRK sarcomas. I also just briefly wanted to thank Marisa Nucci, who gave me a lot of the smooth muscle pictures, Brendan Dixon, who did the RNA sequencing on a couple of the tumors I showed, as well as Emily Goebel, who worked on the UTROSCs, and Danielle, who worked on the NTRK rearranged sarcomas. And if we have some time, I'm happy to take questions, or people can email me if we're running out of time.
Well, Emily is on. I see that. There's no questions in the chat, David, but there's just some positive comments towards your session today. I'll pass it over to Anna. I just wanted to say that we had 2 other participants who were planning to present as well, and we unfortunately ran out of time. So just wanted to thank them, and we'll get to them next session in the fall. Go ahead, Anna.
Thank you very much, everybody, and thank you, David. I can see still, even in acknowledgements, you still have a lot of Canadian connection, and I hope it will stay the same way. Always happy to see you around, and congratulations on all achievements and all your recent papers as well. And thanks a lot for sharing your insight. I personally learned quite a lot of tips, and sometimes we think about things, but it's good to hear that someone is using that. So thank you so much. And thank you for coming today to our Zoom session. And to everybody, just please remember to fill out evaluation form. You can see the link in the chat box. And especially if you need the CME certificate, and also please share your feedback about the session. And so far, David, there are so many things and so many wonderful notes to you. Everybody's super happy.
Thanks so much for the invitation to speak. It was a lot of fun, and it was great to see so many faces, so many familiar faces and names, at least virtually.
Yeah. And thanks, Anjelica, for the wonderful moderation, and see everybody on our next events. And please follow up on the website where you can see recorded sessions. Bye-bye for now.